Hi, welcome back to Nursing 130. This is Jan Johnson, and today I'd like to talk to you about intrapartum, or labor and birth. Labor and birth represent the end of the pregnancy in the uterus and the beginning of life outside of the uterus for the baby. If you're wondering why we call it labor and birth and not labor and delivery, it's because several years ago they started to call it labor and birth to put the experience back in the hands of the mother, give her more control, kind of getting away from the medical procedures where in delivery the physician, the nurse, and everyone else manages her pregnancy and her delivery. So even though we know thousands of babies are born every day, what are the factors that affect labor and how it goes? Some textbooks say there's 4 P's of labor and some say 5. Your textbook says 5 P's of labor, so I'd like to talk to you about those. At least 5 factors affect the process of labor and birth. The 5 P's are the passenger, which is the fetus and the placenta. How big is that fetus? What kind of obstacles is it going to have coming down the birth chute or the birth canal, so to speak? The passageway, which is the birth canal, the bony pelvis, the sacrum, and the coccyx. We need to make sure the pelvis is the correct size for the baby to be able to fit. The powers. How adequate are those contractions? What position is the woman who's in labor in? Certain positions like squatting will benefit. Other positions where the legs are open wide is going to help open the pelvis up and allow more room, especially at the end of labor. And what psychological response is there? How is this woman's anxiety affecting her outcomes? Understanding and preparing for the childbirth experience, the amount of support she gets from other people. What emotional status is she in right now? Is she calm? Is she confident? Does she anticipate a good outcome? Or is she scared and so fearful that it's tensing her up and causing all sorts of chemical responses inside of her? And what are her beliefs and values? Is this normal? Is this a normal part of life? Or what is her, what are her cultural values? Okay, so starting with the first factor, which is the passenger or the fetus in the placenta. The size of the fetal head can be a big issue, as you can imagine. If that head is too big to come through the pelvis, they call that macrosomia. That's often a reason for C-section, one of the reasons given, I should say, on the surgical OR report. Sometimes the pelvis isn't the right size for that particular baby's head also, and that can be cephalopelvic disproportion, which is something we'll talk about later on. Fetal presentation, is the baby coming into the pelvis head first or cephalic? Frank breech, which is when it comes butt first. Shoulder. Footling, which is when one foot presents through the opening. And it's rarely full face. That's when the baby is in a hyperextended state and comes down face first. The fetal lie, that's the relationship of the long axis of the fetus to the long axis of the mother, which means the axis of the angle of the baby's spine in relationship to the mother's spine. They're usually parallel to one another with the head coming first. That's called the vertex, and that's the most common presentation. The breech is, as I mentioned, we'll talk in another slide about that. Transverse is when it's laying on the mom's side, one side to the other side of her body. Oblique is when it's coming down at an angle. The breech, transverse, and oblique are possible, but they're less common than the vertex head first position. Fetal attitude. That's the relationship of the fetal parts to one another. The normal attitude is a flexion of the neck, arms, and legs. That's especially important as that baby's coming down. I believe in simulation we talked about if it's coming head first, looking sunny side up, things don't fit quite the same. So we want that neck to chest position, which is called flexion. The fetal position, that's the relationship of the fetal presenting part to the maternal pelvis. If you recall when you saw that bony structure of the pelvis in simulation, we look at the 3-letter notation, and we'll talk about that in just a moment. Okay, so this is the fetal head at term, meaning when the baby's fully developed. You can see the frontal bone, the parietal bone, the occipital bone, and the temporal bone. As we look down to figure B, you can see the lambdoidal suture, the posterior fontanelle, which is a triangle shape, the sagittal suture, which runs anterior to posterior, the coronal suture, and the anterior fontanelle, that's the diamond shape, soft spot, and the frontal suture. These bones are connected by membranous sutures. As I mentioned, the sagittal suture runs anterior to posterior. The membrane-filled spaces called the anterior and posterior fontanelles. The anterior fontanelle is the diamond in shape, but it also is referred to as the soft spot by parents. It closes by 18 months after birth. The posterior fontanelle is triangular in shape and closes at approximately 6 to 8 weeks after birth. Those are going to be important things you're going to want to know about when those fontanelles are expected to close. The sutures and fontanelles allow for brain growth, and the bones aren't fused together, allowing for the overlapping of the bones to mold or fit into the maternal pelvis for childbirth. Most molding on the newborn's head resolves within 24 hours to 3 days. Okay, as we were speaking about a minute ago, these are the different positions that, if you're looking at using these terminologies, the lie in the first one is frank breech. It's a long lie, meaning that it's parallel to the mom's spine, the baby's spine in relationship to the mom's spine, but it's coming, this one would be called frank breech or butt first. Presenting part is the sacrum in this because it's pulled up. The attitude is flexion, except for the legs at the knees, which are fully extended in frank breech. Here we have a single footling breech. That's when one foot drops through the pelvis first. In figure C, we have a complete breech, and you'll notice that this baby is in general flexion, which we talked about, where the legs and the hips and the chin is to the chest and the arms are flexed. In figure D, we have a shoulder presentation. As you can see, this is not going to fit coming down the opening. As you may remember from your simulation day, or some of you may get this experience actually at the clinical site with a pelvic model. When determining the position of the presenting part, we look at the relationship of the fetal presenting part to the maternal pelvis. And when I say presenting part, it's that part of the fetus that lies closest to the internal os of the cervix. It is the part of the fetal body first felt by the examining finger during a vaginal examination. So it's usually represented by a 3-letter notation to describe the fetal position. So the first letter is for R or right, L for left, indicating which side of the maternal pelvis the presenting part is towards. Remember, we're looking at the maternal pelvis in her right or her left. The second letter indicates a landmark of the fetal presenting part. The most common position is occiput or O, mentum, which is the chin, sacrum for breech births, acromion process for shoulder births. And the third letter indicates the relationship of landmark of presenting part to the front or back side of the pelvis. So is it the anterior side of the mom's pelvis that the occiput or the presenting part is by, or is it the posterior? Transverse, which is mentioned, or I should say shown in this slide as LOT and ROT, you can see that's the sagittal suture line we're looking at, and that's going side to side instead of anterior to posterior. This slide just shows the labels of the fetal head presentation in the 4 positions. It also shows the biparietal diameter, which is the widest part of the fetal head entering the pelvic inlet. So you could kind of see, especially from that second figure B, the biparietal diameter is generally 9.25 centimeters. When the head comes down or presents into the pelvis in that position, it fits best in a gynecoid pelvis. And in order to have that position, the chin is slightly flexed. As you can see in figure A, the mentum or the chin, if it presents there, that occipitomental angle would be 13.5 centimeters. If it presents syncoput, which is the frontal bone, the frontal side, that's occipitofrontal, that's going to be 12 centimeters. And the best position, though, is going to be with a biparietal diameter of 9.25 centimeters, and that's going to be in the vertex with the occiput presentation. Again, this just shows those different angles in relationship. The best position for the fetus to present in is with the chin tucked or in the flexion, so the biparietal diameter is smallest and will fit easiest into the pelvic inlet. So when I check the pregnant patient vaginally, I would hope to feel the posterior fontanelle and the occiput to indicate that the baby's head is flexed forward with the chin towards the chest. Okay, so this is the maternal pelvis. And as we're looking at this baby coming down, dropping down into the true pelvis, we're looking, if you'll see the numbers -5, -4, -3, -2, -1, 0. 0 is at an imaginary line between the two ischial spines. And then you have +1, +2, +3, +4, and +5. When you see the term perineum down there, that's when the baby is actually in the external anatomy and crowning. If the presenting part is directed towards the pelvis but can easily be displaced with upward pressure from the examiner's gloved finger, it's called ballotable and it's not engaged. So when I'm doing a vaginal exam with my gloved hand, and at this picture the baby's head is at a 0 station, we would call this engaged. But if it were actually higher, not this far into the pelvis, and when I reached up, if I touched the baby's head and it floated away from me, that's a term that we call ballotable. That, of course, that would be with the waters intact. The bag of waters has not broken at that point. But as this baby descends down, I want you to remember that stations the relationship of the presenting part to the ischial spines of the pelvis. It's measured in centimeters. So -1 to -3 stations are above the ischial spines. 0 station would be engaged. And as it descends down lower, getting ready to be delivered, it's a +1 or a +2, and +2 we often call crowning. That's when we visibly can see the head outside of the vagina. And so I know your book talks about -5 all the way down to +5, but we rarely use those terms. As a general rule, we start out with -3. If it's any higher than that in the pelvis, we call it high, or if in fact we could push it out of the pelvis and it floats away, that would be called ballotable. So general terms, not to confuse you, what you will probably hear clinically I should say, is okay, next I'd like to talk about the second factor, and that's the passageway or the birth canal. And it's composed of the bony pelvis. Your book talks about 4 different shapes of pelvises, but gynecoid is the most common shape in about 50% of the moms. And that's some books describe it as the female pelvis. But that seems to allow the head to descend properly and everything has great outcomes. The cervix, and with the cervix, for the passageway, we're looking for effacement and dilatation or dilation. Pelvic floor muscles, that helps the fetus rotate anteriorly as it passes through the birth canal. The vagina, and it can dilate at term to allow the fetus to pass through it. And the introitus, which is the external opening to the vagina. The next factor I'd like to talk about are the powers. A combination of involuntary and voluntary powers or contractions combine to expel the fetus and placenta from the uterus. The primary forces or the involuntary forces consist of contractions of the uterine muscle fibers, which are stimulated by a pacemaker in a thickened muscle layers of the upper uterine segment. So that's that top part of the fundus, and that gets thicker as the contractions get ready to happen. That's a big muscle, so as that upper part contracts, it pushes the fetus downward over the uterus in waves. So it's kind of it's a coordinated movement, starting with the pacemaker, which causes the contractions, and then that upper segment, which is so strong, pushes that bag of waters in that baby down against the cervix. So remember, the uterus is a big muscle. As it contracts, it exerts pressure on the baby and the bag of waters and pushes them against the cervix, causing the cervix to thin, or what we call efface. So during the first stage of labor, these repeated contractions, if they're adequate in strength, will shorten or thin out the cervix, which starts out around 2 to 3 centimeters thick. That's 0% effaced, and ends up as a very thin edge when effacement is complete or at 100%. With first pregnancy, the cervix usually effaces almost completely before it dilates. With the second or more pregnancy, the effacement and dilatation process occur together. When the presenting part of the fetus reaches the perineal floor, the mechanical stretching of the cervix causes that vagina to open. The stretch receptors in the posterior vagina cause a release of endogenous oxytocin that triggers the maternal urge to bear down. This may occur without full cervical effacement, so the woman's discouraged from pushing until the cervix is fully dilated to prevent damage to the cervix or swelling of the cervix, which could actually slow her down. And all of a sudden, someone who was 8 or 9 and the woman was so pushy, or let's say 8 centimeters, and she pushes against that cervix, it can swell it up. And then we have to wait for that swelling to come down before it can dilate further. Very, very frustrating situation. And as I mentioned, the secondary powers, that's voluntary. Once the mom pushes against, when she feels that Ferguson reflex kick in, she wants to help push, and she'll be encouraged to bear down at that point. That would be primarily, the secondary powers would be in the second stage of labor, as we'll talk about in a few minutes. This is just another picture of the dilation or the effacement. You can see a really clear picture of the internal os and the external os, and if you keep your eyes as you go to figure B, the internal os is slid up, that cervix is getting thinner or more effaced, to where in figure D it's what we call fully effaced, and that cervix is actually dilated. The next factor affecting labor is position, and this is maternal position during labor. Position affects the woman's anatomic and physiological adaptations to labor. We're going to encourage her to have frequent position changes to relieve fatigue, increase her comfort, and improve circulation, that's fetal circulation, and also her circulation. The laboring woman should be encouraged to find positions most comfortable to her, but we're going to keep a close eye on that fetal monitor in a hospital setting because some positions may not be as favorable for the fetus. You'll be reading and hearing about positioning women in labor and nursing care of the family during labor and birth, which is a chapter a little while from now. The fifth factor affecting labor is the psychological, and it's part of the labor process. Again, I mentioned anxiety or fear decreases the woman's ability to cope, and the maternal catecholamines, or the stress hormones, are known to inhibit contractility and placental blood flow. So sometimes if that woman's pain is so bad, she's actually holding up her labor. So relaxation augments the natural process of birth. So if we can get her as comfortable as possible and help her cope with her breathing, with our non-pharmacological, and if she requests our pharmacological assistance to help her become as relaxed as possible so we can speed up the process of labor for her. The signs of labor. Isn't that a pretty picture? The process of labor is the process of moving the fetus, the placenta, and the membranes out of the uterus and through the birth canal. Various changes take place in a woman's reproductive system in the days and weeks before labor begins. Labor can be discussed in terms of the mechanisms involved in the process and stages a woman moves through as she's getting ready to have her baby. Some of the signs preceding labor, and not all women feel or are symptomatic of every single one of these, but lightening or dropping is mandatory. That's when that baby drops into the pelvis. Her fundal height will actually decrease from her last antepartum visit, so it's kind of exciting. Women often get told, wow, the baby's really dropped, so that's why we say the term dropping. Cervical changes such as a bloody show, which can be a brownish blood tinged mucousy discharge, vaginal discharge. Her bag of waters might break or possible rupture of membranes. She may get a sudden burst of energy. We call that nesting. Sometimes they want everything done right away. They may have frequent but irregular uterine contractions or Braxton Hicks contractions. May have some urinary frequency as that baby drops down lower into the pelvis. It's putting her more pressure on her actual bladder. She may develop a backache. That's those early labor pains. Increased vaginal discharge and possible weight loss. Sometimes they may also get diarrhea. Just women present differently, but these could be some of the preceding signs. The physiology of the onset of labor involving the progesterone and the estrogen. The progesterone causes relaxation of the smooth muscle tissue, and the estrogen causes stimulation of the uterine muscle contractions. The connective tissue loosens and permits a softening, thinning, and opening of the cervix. All of these are responsible for the cervix changing and allowing that baby to descend further into the pelvis. The thinning of the cervix, as we've talked a lot about so far, the muscles of the upper uterine segment, as I mentioned, shorten and thicken, and that causes the cervix to thin and flatten. The fetal body is straightened as the uterus elongates with each contraction. The pressure of the fetal head causes cervical dilation. The rectum and vagina are drawn upward and forward with each contraction. And during the second stage of labor, the anus everts. It actually kind of what some people call flowers, as the pressure is so great down there. I'd like to talk to you about the stages of labor. There's 4 stages of labor. The first stage is broken up into latent, active, and transition. It's the onset of contractions to full dilation of the cervix. The second stage is in 2 parts, called the latent and then active pushing, and that's full dilation to the birth of the fetus. The third stage is birth of the fetus until the delivery of the placenta. And the fourth stage is the delivery of the placenta until the mother stabilizes. And looking at this, you can guess that the first stage is by far the longest. And that's from the time she begins to contract and the cervix starts to change until the cervix is fully dilated. In a first-time pregnancy, it's going to be very long. It can be 12 to 18 hours of actual first stage. I love this picture. This is to give you the idea of baby coming down the chute, and that's the 7 cardinal movements of labor. It's what has to occur, or what the baby goes through position-wise, in order to make it all the way down and to be delivered. There's 7 cardinal movements of the mechanism of labor that occur in a head-down presentation. They are engagement, descent, flexion, internal rotation, extension, restitution or external rotation, and expulsion. So engagement is actually the dropping of that baby down to the ischial spines, as we talked about, the 0 station. Descent is the progress of the presenting part. The flexion, that's the chin to the chest. The internal rotation is the smallest portion of the baby into the pelvis. The smallest head angle, I should say. The extension is when the head reaches the perineum. External rotation or restitution is one you may see as a test question occasionally, and that's the realignment of the head after it passes under the symphysis, and it's turning in order to align the shoulders. And then the expulsion is actually the whole birth of the fetal torso. So once that head comes out, the babies, they'll suck out the mouth and then the nose. And then you'll see the head kind of start to shift and turn. That's that restitution or external rotation once the baby's out, the head's out. And then it's going to align those shoulders, anterior, posterior. And we deliver the anterior shoulder first usually by dropping the head down slightly, and that anterior shoulder comes out. And then they're going to protect that lower perineum, slightly lift on the head, and that's going to deliver that posterior shoulder. And then with the expulsion, which is the rest of the fetal torso for the completed childbirth. We're going to dry that baby off and get that baby skin to skin. These are just the different positions as they occur with the mechanisms or the cardinal movements of labor. I'd like to talk to you about the physiological adaptation to labor. These changes occur with the fetal heart rate, fetal circulation, and fetal respiratory rate. So normally fetal heart rate is 110 to 160 with accelerations, which is a reassuring sign of a well-oxygenated fetus in utero. The responses to the stressors such as the vaginal exams, the uterine contractions, the head compression, the cord compression, uteral placental insufficiency, they can result in decelerations of the fetal heart rate. Fetal circulation can be affected by uterine contractions, the maternal position, the umbilical cord blood flow. Contractions can decrease circulation to the fetus, resulting in abnormal fetal heart tones. Fetal respiration, I want you to be sure to watch those Khan Academy videos that are posted on Blackboard and reading your text for changes of the fetal respiratory system as the fetus passes through the vaginal opening, compressing the chest, pushing the fluid out of the lungs, and allowing oxygen to enter the newborn as the newborn takes his or her first breath after birth. And regarding maternal adaptation, there are cardiovascular changes, respiratory changes, renal changes, integumentary changes, musculoskeletal, neurologic, gastrointestinal, and endocrine changes. Cardiac output increases 15% during the first stage, 30 to 50% during the second stage of labor. The heart rate increases in the first and second stages of labor. And just to refresh your memory again, the first stages is when all the dilation is occurring, and the second stage is during the pushing. The blood pressure systolic increases in the first stage. Both the systolic and diastolic increase in the second stage or the pushing stage. White blood cells increase, respiratory rate increases, temperature slightly increases, there may be proteinuria, gastric motility decreases. Therefore, they may have nausea and vomiting during that transitional phase of the first stage and also during the second stage of labor. And the blood glucose levels decrease. Okay, a pregnant woman is at 38 weeks of gestation. She wants to know if any signs indicate that labor is getting closer to starting. The nurse informs the woman that this is a sign that labor may begin soon. Does she have a weight gain of 1.5 to 2 kilograms or 3 to 4 pounds? Is that a sign that labor is going to begin soon? Or an increase in fundal height? Does she have urinary retention? Or is it possible she might get a surge of energy? Give you a couple seconds to think about that. The correct answer is D. Women speak of having a surge of energy or nesting prior to going into labor. Not all women do, but it is a very classic symptom. I hope you enjoyed this presentation. I'll talk to you in a few. Have a great day.